Ball State Community College's Respiratory Care Program, and today I will be discussing how to run a megacode with pulseless cardiac arrest. When assessing the patient and you discover that they are in pulseless cardiac arrest, you will want to start CPR immediately. You will also want to give them 100% O2. Once you realize that they are in pulseless cardiac arrest, you will want to look at their EKG monitor and determine what their heart rhythm is. If they're in ventricular fibrillation or pulseless VTAC, you will want to shock immediately. Here in the USA, we use biphasic shock. This sends the shock from the upper right pad to the lower left, and then back to the upper right. You start with 200 joules, and if that doesn't work throughout the sequence, you will use 300. After the shock, you will want to do CPR for 2 minutes, which is 5 cycles, and also you will want to establish IV or IO access. This will be to better administer drugs and have a better effect. With the CPR, you want to use a 30-to-2 ratio. This will be 30 compressions to 2 breaths. After the 2 minutes or the 5 cycles, you will want to reassess the EKG for the rhythm. If it is shockable, you will shock again. This means they are still in ventricular fibrillation or pulseless VTAC. After shock, you'll want to immediately continue compressions. On this round, you'll want to give epinephrine, 1 milligram, and after this, you'll do it every 3 to 5 minutes. The first dose of epinephrine can also be substituted with a vasopressin. Epinephrine and vasopressin, they increase the heart rate, which increases the cardiac output and causes vasoconstriction. This helps with the shock rhythm because you have better cardiac output and allows the patient to better control their blood pressure and get their heart rate back up to normal. You'll also want to consider an advanced airway at this point to make sure the patient is ventilated well and oxygenated. After your 2 minute or 5 cycles, you'll want to assess the rhythm again. If the rhythm is still shockable, you will shock again. At this time, you'll probably be at 300 joules, because obviously it did not work the other 2 times. And you'll want to start CPR immediately again. With this cycle, you'll want to give amiodarone, which is an antiarrhythmic. The first dose will be 300 milligrams, and then the second dose will be 150 milligrams. You would want to give the second dose on the next cycle of shock and CPR if it doesn't work this time. You'll also want to consider what your H's and your T's are. These could be from hypothermia, hypovolemia, toxicity, and you'll want to consider how you're going to treat those to reverse the cause. If you're going through this cycle and you aren't in VF or VTAC anymore, you'll have to go to the pulseless electrical activity or asystole algorithm. This includes CPR for 2 minutes, 5 cycles, and you'll obtain the IV and IO access. You'll also give the epinephrine every 3 to 5 minutes like you did in the other algorithm, and consider the advanced airway. After the 2 minutes, 5 cycles, you'll want to assess the rhythm again, and if it's still in the pulseless electrical activity or asystole, you'll want to continue CPR for 5 cycles or 2 minutes. This is where you'll assess your H's and your T's and treat the reversible cause. And if it goes into a shockable rhythm, you'll go back over here to this algorithm. And if there's no sign of spontaneous circulation, you're just going to want to keep doing this algorithm until the code is called and the patient doesn't have the ability of coming back. Also with these, for the pulseless, you don't shock at all, and with the VF and the VTAC, you do. This will be your unsynchronized shock, and what that means is at any time you can administer the shock. The healthcare professional will be the one administering that. And there's also cardioversion that you do for patients who are in atrial flutter, AFib, SVT. You want to start them at 100 joules, and that shock, you actually have to sedate the patient. They're usually coherent. You start with 100 joules, and if they're an SVT, Torsades point, you start with 200 joules. And this will usually convert them back to a normal heart rhythm. If a patient is in SVT or VT too long, it'll usually go into VFib. So you don't want them to get at that end and have to go through this algorithm, because it's a lot harder on the body than just a cardioversion. Let's see. And if the patient does go back into spontaneous circulation, you'll want to assess them for the post-cardiac arrest care. And this includes just monitoring their vitals 24/7. Epinephrine, you'll want to, not epinephrine, but non-epinephrine, you'll want to give them to maintain that vasoconstriction and blood pressure so they can maintain their perfusion. So, but this was the algorithm for Omega Code with pulse